Welcome, and thank you for joining this 8th edition of the CCD Rounds. My name is Niels Lund. I'm the global lead for Cities Changing Diabetes, and I'm also Vice President of Health Promotion and Prevention at Novo Nordisk. CCD means Cities Changing Diabetes, and Cities Changing Diabetes works to address urban diabetes, particularly with a focus on the most vulnerable people in cities. The partnership was established in 2014, 8 years ago, and now includes more than 40 cities around the world. With more than 40 cities around the world spanning 8 years, we have a number of excellent examples of what you can do to address vulnerability and improve health for the many people living with and at risk of diabetes around the world. And this is what the CCD Rounds is all about, sharing these best practices and hopefully you can learn from them and bring them to your neighborhood also. Today, I have the pleasure of introducing Charlotte Glümer, who is the director of the Center for Diabetes in Copenhagen. Charlotte will present how an integrated diabetes care model in Copenhagen works to improve the health of vulnerable citizens. Understanding vulnerability has been one of the core focus areas of the Cities Change Diabetes since its inception, and Copenhagen was one of the first cities to join, so there's a lot of interesting things to learn. Charlotte will be presenting for, let's give or take, 25 minutes or so, and then we'll go into a moderated Q&A session. The moderator will be me, and then I will feed your questions as you feed them in to me, and then we'll have a good discussion around that. On your screen, you can see a small question mark to the right, and if you already now have, or during the presentation, have a question, then click the question mark and enter your question there, but you can also do it once we're done here. But let's get right into it, and happy to hand over to you, Charlotte, for your presentation.
Thank you, Niels, and thank you for being a part of this CCD Rounds. I'm Charlotte Glümer, and I'm a director of the Center for Diabetes and Heart Diseases in Copenhagen City. I will, through this presentation, give you a brief overview of our history and then go into how we work, some of our main results, and at the end of the presentation I will just elaborate a little bit about how we have succeeded in the last 6 years. Actually, as Niels mentioned, we have been a part of CCD since it started in 2015, and we had the analysis of the rules of half and the vulnerability analysis. And this shows us that we have in our population 5.1% of the population have diabetes. It corresponds to around 20,000 inhabitants, and 10 to 20% are at risk of having diabetes. We also saw in our analysis that 50% do not reach the treatment target goal for patients with diabetes. And when we looked into our vulnerability analysis, these people was particularly men. They are over 45 years old. They have short education. They are unemployed. They're living alone. And actually, diabetes was not the top one priority. They have a lot of competing problems. So maybe diabetes was number 9 or 10 of their priority list. So upon this analysis, our former mayor in health, Nina Thompson, and the politicians decided to make an action plan in 2015, and it was implemented in 2016, an action plan for diabetes in Copenhagen. And one of the tracks in this action plan was to establish the Center for Diabetes in Copenhagen City. We had some experiences for another center, a center for cancer diseases, and we have looked into this center to be inspired how to work in our center. I can say because we have succeeded a lot the last 5 or 6 years, in 2020, the municipality decided that we also should take care of patients with cardiovascular diseases. So now we have both diabetes and cardiovascular diseases in our center, but I will just focus on diabetes today. in our center, which is in this street, actually we are starting up building a new center, a new building here in 2023. But here we are taking care of patients. We're doing patient management for people with diabetes or cardiovascular diseases. All patients are either referred by GPs, hospitals, and some are actually coming as self-referrals from the road. We started in 2016 by being 16 employees, and now we are about 45 to 50 employees in the center. We have a big department of healthcare professionals with trainers, dieticians, and nurses. But we also have a department of development and quality improvement, which are mainly academics that are in this department, and they actually facilitate all improvement in the center. But in the action plan for this center in 2016, it was stated that we should be a beacon nationally and internationally in diabetes rehabilitation and diabetes management. And we cannot be a beacon without partnerships. So therefore, we have worked hardly on building on partnerships with the Danish Diabetes Association. We are all now in the phase of building partnerships with the Danish Heart Association, and we have a partnership with Steno Diabetes Center Copenhagen, which is formal, and we have some improvement projects with them. But we also work with other research groups in physical activity, for example, or other Steno centers in Denmark. The people that are coming into our centers are people with type 2 diabetes. We see up to 2,000 patients every year with type 2 diabetes or cardiovascular disease. Actually, this has decreased the last years due to the COVID-19, but now we are seeing a steadily increase of referrals. Again, we are happy about. The people are mainly new diagnosed, but we also have people that have had diabetes for several years. They do not have a lot of complications, because if they have many complications, they're having the rehabilitation and diabetes management programs at the hospitals. But most of the people in Denmark with diabetes are seen by the GPs and are therefore coming into the municipality to have rehabilitation and diabetes management programs. In the center, we have actually succeeded really a lot with having a huge group of people with a non-Western ethnic background. Actually, 35% of our Copenhageners coming into our center have a non-Western ethnic background. And if you are looking into the proportion of people with diabetes that are of non-Western ethnic background, this is 20%. So we have an overrepresentation of people with another ethnic background, which can be a proxy for that we have people with that are deprived because they are normally also have a short educational background. As you can see, we also see a lot of people with. Actually, our action plan has just become. We have a new action plan here in 2022, and our new strategic aim is that Copenhageners with type 2 diabetes and cardiovascular diseases shall manage their daily life and maintain physical and mental health. We have the target group are both people with diabetes or cardiovascular disease, but we also now are trying to take in people at high risk of developing type 2 diabetes or cardiovascular diseases. So it's actually people with pre-diabetes or metabolic signs of a metabolic syndrome. We have four tracks in our action plan now. It's track 1 is actually, I think, the most important one at the time. This is how we work cross sectors, collaborate cross sectors. It could be across sectors in our own departments or in our own municipality, but it is also how do we work together with the hospitals and the GPs, and we have actually to make this even stronger than we have done until now. And track 2 is how to increase equality or equity in health. And track 3 is working with mental health. We know that a lot of these people we are seeing have either depression or anxiety, but also a huge proportion, actually about 40% of the population have diabetes distress, and we have to manage that when we see the Copenhageners in our center. And the last track is that we would like to be a knowledge center for rehabilitation and diabetes and cardiovascular disease management. And we would like to share this knowledge both nationally and internationally. And especially here in Denmark, we would like to share our knowledge to all the other municipalities we have in Denmark, in 98 municipalities across the country. When you're having, I started in this center in 2016 and have built it up together with all the employees, and when we started we talked about which kind of principles and values do we want to work within, and we have actually, this is our 5 core principles we are working in, and the first one is we have to be person-centered and deliver differentiated care. I mean, this is stated in a lot of papers that we should work person-centered and differentiated, but it's really hard to find out how to do it. I mean, in Denmark, we are not, in 2016, we was not used to work as a person-centered and differentiated as we are doing now. So we have actually had a paradigm shift in our center, and I think we work with a paradigm shift in this area in the entire country, maybe also internationally. We have a broad view of health, so we both manage to look into physical and mental health. To be a beacon and to develop new activities, new way to work, we have to have active user involvement, and this is both for the patient or the citizens. This is for the civil society, but it also includes that we have to involve the healthcare professionals. They are the ones that know what's going on in the meeting with the patients and how to solve some of these problems. The fourth principle is that we would like to be evidence-based, but it's not always we have evidence in this area. So then we are working on the best knowledge or practice we have. And actually we want to be a laboratory to create evidence, and therefore we have the last principle. We really work on collaborations and networks, and especially also networks with researchers, so we can evaluate what's going on, develop new ways to work, and maybe create evidence together with them. When you're coming into our center, you will start to have a consultation or a dialogue where we have an initial assessment needs, where we look into what matters for the citizen, what is their motivation for changes behavior or other things we can offer. And then we, together with the citizen, planning the goals and a plan for the intervention. And under the way in the in the period they are in the center, we have follow-up dialogues, maybe 1, maybe 2, maybe 3. It depends on the needs. And at the end, we're making a concluding consultation where we are talking about what's now, what is the goals and the plans for the coming future, what should we write to the doctor that the plan are, so he or she can follow up on these plans. In the initial consultation or dialogue, we are using patient-reported outcome measures. It's a questionnaire. It's a national questionnaire we have developed during. We have been in that. We have also been in this. But we have also developed this together with the clinicians, and this is a questionnaire about 80 questions, and the patient or the citizens have filled this in before the meeting in the center, and when they are sitting together with the healthcare professional, they have this dashboard, and they can look into the dashboard. Where are the problems? Where are the needs? And what should we then plan? So this is actually a way to make dialogue and decision making together with the Copenhagener or the citizen, so they are involved in what to do now in the center. Because when we are planning the interventions in the center, it's not a package. Because this person-centered approach are really important for us to create equality in health. Before I started, and I think still it's going on some in other places, and maybe also in our own place. But we gave the same amount of interventions for every people, and we know that we've thought that. Every citizen have the right to have equal treatment. But we also know that the needs are different from individual to individual. So maybe this kind of approach actually increase inequality in health. So therefore, we are working through the middle of equity. So some people needs more than others. And this is actually, I think, the paradigm shift in the healthcare professionals' minds, that they have to have this in mind when they're sitting in front of the citizen, because we would like to help everybody and please them maybe, so they get a lot of interventions, and maybe some of them do not need these interventions. So this is actually really an improvement in the healthcare professionals' minds we have worked a lot with. But as a municipality or system, actually, I think in the common future, we also would like to work on how do we decrease the barriers, the systematic barriers that are in our systems, barriers that create inequality. It could be, for example, how do we handle health literacy in our center, in our municipalities? How is our letters written? What do we do when they are not coming into our center as planned, and so on? So this is, I think, something we would like to work more in, look more into in the coming future. But the middle here is how we work now in our center. So when they have had this initial dialogue or consultation, they can have different. We do have a lot of different approaches. Actually, we have about 30 different kind of classes they can have. We have different. I will come back to that. Different classes in training. We have also have a peer support program developed, and we now are we have in the last years worked in a deprived areas, Tingbjerg, and now are really focusing on how do we reach these citizens in Tingbjerg, where we have a lot of people that are out of labor market and have another ethnic background than Danish. But normally they can have self-management support. And in these classes, we're talking about what matters to me as a patient with diabetes. How do I manage the chronic diseases? Risk factors, motivations, and goal setting are one of the classes we have. Mental health and well-being. How do I cope with the disease, and then how do I communicate with the healthcare professionals, which also is really important to empower when you empower people with diabetes. And when it comes to physical training, we have a lot of classes outside. Actually, most of our classes is outside, but we also have classes indoor. When we are outside, we use all the outdoor facilities we have in this wonderful city we are situated in. There's a lot of recreational parks and as we use. We have fitness, we have ball games, but we also work on mental health. We have yoga classes, meditation classes, and these are mostly in the recreational areas we have in the city. It's not only about physical training when we have these classes. It's also about relations, network, and how do we secure that the continue this training after they are ending their intervention in the center. And another last class you can have is a cooking class where you have supervised cooking, you socialized, eating together, you have practical skills, and you learn about healthier alternatives. All these kind of interventions we primarily have in classes, but if it's needed, you can also have it as individual meeting with a healthcare professional. We have the classes both in daytime and in evenings, and we do have them in different languages. We have an interpreter in Urdu, Arab, and Turkey, which are the main languages in Copenhagen. So everybody can have it in their own language. But it's not only seeing these patients or citizens, it's also about how do we be a beacon, how do we improve what we are doing. And we have worked, therefore we have a department of improvement, and actually we are working on data. We are a data-driven center, so we are looking into data not every day, but every week at least. And actually, I have worked with data a lot with the healthcare professionals. So we have meeting every month where we are looking into our data, how many patients are referred, do they participate in our interventions? If they're not participating in our intervention, what do we then do? Is it the wrong intervention they are offered, or do we not have the right interventions for the citizens? That's what we're discussing a lot in our improvement group. But we also make a lot of research. We have made some research with a research institute where we are looking into how much physical activity is enough for the patients. Is it 3 times a week, and how intensity should we work offer the patients? And these results are now being analyzed. But we also have made an outcome measurements. It's not normally in the municipalities in Denmark that you measure your results of your interventions. So we have made a huge outcome measurement where we have both included a questionnaire questionnaires on lifestyle, on mental health, and so on, diabetes, de-stress. But we have also made objective measures as blood pressure, weight, and height. And we have made blood sample measures. We have measured, for example, HbA1c. And here's just some of our main results. Actually, we have seen a 35% increase in the certainty to tackle diabetes. It's increased from 55 to 70%. We actually, regarding diabetes distress, this is actually one I'm really proud of. We have decreased diabetes distress with 42%. In the beginning of the intervention in the center, about the 40% are de-stressed when they're coming in, and it's only 22% that are de-stressed after they have been into our center, and it lasts 6 months after they stop the interventions. We also see a mean BMI decrease from 32.2 to 31, and a mean HbA1c decreased with 6.1 millimolar per mole, which is also a really nice result. And I think maybe it's because they're more physical active, as you can see at the bottom, but it could also be because of they are empowered to take their medicine. But it's not only the municipality that are taking care of the citizens. Actually, collaboration across sectors are really important to secure that we are taking care of these citizens together. So therefore, we have developed population health management programs with GPs, hospitals, and our center. And this collaboration have a basic principle on relational coordination. They are bottom up. We're taking decision together and we share data. We have decided that the common goal for the population are that we would like to improve quality of life, reduce morbidity and mortality, but we then made a driver diagram to see how do we then reach these goals. And we have worked really strongly through this, having knowledge between nurses, having meetings every month, but then COVID-19 came, and then now we have virtual team meetings actually every second week, where we discuss patient cases and have knowledge sharing between the sectors. So we know each other, and it's easier then to take the telephone and talk to the healthcare professionals, either at hospitals and the GPs. We have collecting data every year, and we can see on these data that now we have increased the proportion of individuals that are having their yearly consultation or status at the GP or the hospitals. We have increased the numbers of patients that are referred to the center, and therefore we hope this is a proxy of increase or improve quality of life for the patients and reduce morbidity and mortality. We cannot measure that effect in this this little collaboration we have developed. So at the end, this is just a briefly speak on our center. I will say that why do we succeed? We have a mayor with political will and huge ambitions of the city. We are a big city, so therefore we have these ambitions in Denmark. We also, because we are one center and not 5 centers, we do have the critical numbers of citizens, so we can have this person-centered, differentiated approach for the patients. So we can have a lot of different classes. We do also have the critical numbers of healthcare professionals that can develop new things that can collaborate together. Instead of being one nurse, we have 7 nurses. And then we have had a strong and ambitious leadership in our center. We know we have this action plan, and we have worked hardly through coming to we have actually the plan is fulfilled, and now we have the new plan, and then we have this quality improvement and user involvement a cornerstone in our work, and we offer ourselves as a laboratory for researchers, so we can be a beacon in the development of new methods. So that's a speak talk of Center for Diabetes.
Super. Thank you very much, Lotte. I mean, really impressive and an exciting presentation, but also an exciting example about what works in this area. Now we'll go into a Q&A where I'll be the moderator. If you online want to join, click on the question marked in the upper right part of your screen, and then write in your question, and then somebody will get it to me on the screen that I'm looking at now down here. But as we await those questions coming in, a couple of questions I've had to your presentation here. I'm really impressed the fact that you have 35% with non-Western background and therefore have an overrepresentation, as you said. That's I think this is extraordinary. What are you doing right? Is that the values, or what are the 1 or 2 things? Is it the person-centeredness and the differentiated approach, or what is it that in your view, leadership, or what do you think it is?
Yeah, actually, I think it's a combination. I think one is that we are one center, so we have the critical numbers of citizens with different kind of languages. So we can have a lot of classes during the year instead of have one in Arab and one in Urdu and one in Turkey. Now we have classes every month or every second month in these different kind of languages, so they don't have to wait on being in these classes. That's the one of it. The other one is that we have a strong collaboration with the Steno Diabetes Copenhagen, where we have actually developed specific tools for ethnic minorities. So this is really a high-end tool of how to tackle or discuss diabetes management with which is culturally sensitive for these kind of patients. Before that, we have one tool. Now we have a specific tool for patients with another ethnic background. I mean, this may be shared across the world, I think, because it's really impressive what they have developed, and we have developed it together with the Steno Diabetes Center and have evaluated here. So I think now the GPs know that we have a high quality in how to empower people with another ethnic background. So maybe they also refer more people to our center because of that.
It's interesting. So there's a question here online from Klaus in Austin. He says, it takes a village to be successful in diabetes prevention and care. Can you share how you're working with community-based organizations to reach the underserved populations, such as non-ethnic Danes? So, as in addition to the question I just raised, who are you? I know you're also busy with people in Tingbjerg and around that, but can you share a little bit more in terms of how you work with these organizations?
Yeah, we have not actually succeeded with this at the moment. We have been in Tingbjerg in a couple of years, trying to build up relations, and we have actually built up relations with some of the civil societies, but it has been more or less unstructured, going out in Tingbjerg, meeting people there, having a cup of coffees, but we have not made these kind of strong relationships. But actually, at the moment, we are starting a new a project with the Senior Diabetes Center Copenhagen in Tingbjerg, Integrated Diabetes Care in Tingbjerg, where we now will have a social nurse there working full-time with the civil society, going out, try to reach the hard reachable people there, working uh, with other civil society organizations out there, making events where we are talking about diabetes, health, and then maybe screen them for diabetes, or the people with diabetes we will collect or give classes in Tingbjerg. So we are not, I think we could be even better working with the civil society in the coming future.
Thanks. There's a question here online from Nuno. You talked about the way that you organize. People come in and then you design a program and they attend classes. And then the question is, hi there, what do you do when clinical interventions end? So, how do you determine when it ends? And, is it just something that continues, or when do you determine that, well, enough you can do on your own, or you can go back to your GP or something like that?
Actually, this depends on the collaboration between the citizen and the healthcare professional. I mean, they're setting up goals through the intervention or the period that they are in our center. Normally, it was before we have our center, it was a package they have for 12 weeks, but now they can stay in our center for 3 months, 6 months, and even longer if it's needed. I mean, this is really a dialogue, and we are using the person-reported outcome measures to measure whether they have increased. It's going better for them when we are looking in these measures. So it depends. It depends on the dialogue with the patient, and I mean, they cannot be here forever. But if it's needed, they can be here longer than 3 or 6 months. But most of the people are here between 3 or 6 months.
Okay, thanks.
They are welcome to come back if the GP think this is needed.
Thanks. So let's go back 5-6 years to when all of this started. The municipality decided to establish a diabetes center, and I think everywhere around the world there's a large sense of ownership from general practitioners or family nurses of their patients, and then suddenly you come in, and I'm not saying taking away, but certainly coming in as somebody who is doing something else than they're doing. How has that collaboration been? I mean, you've been successful. You've been you've showed your results. You have grown in size tripled from 15 to 50. But how has that relationship been? And how have you tried to avoid any misunderstandings or maybe even conflicts in that regard?
Yeah. Actually, I think first of all, the municipality hired me as a medical doctor, so I am the one of them. So I have the same language. I understand their work. I understand their situation. But actually, I have had a lot of meetings with the GPs. I have been out there being curious of how they are working, trying to give them this kind of talks that I'm doing here. And then I've just been out there many times, drinking a lot of coffee, building up relations. I mean, relations are crucial for all work we're doing together. Relations build up respect and trust. And if you have this respect and trust, then I think we can work really good together, and I think this is the ground principle for every collaboration in the healthcare sector.
Yeah.
So that has been my approach for the collaboration, and also then building up a center with a high quality in the interventions as well.
Yeah, I think you're absolutely right in terms of the continued dialogue with GP, and as new GPs come in, and as things change, and then you have COVID and so on. So those relationships are really important, and it's great that you have a strong working relationship both with the general practitioners but also the specialized care. So each has their own specific role here. You mentioned to the ones online, Copenhagen is a large city, not the world's largest city, but you are one center in one physical location in the city. And you said that you thought it was an advantage to have one center. But would you change it for 5 centers differentiated all over town? Would that you get more people in, or what is your view on that?
I don't think so. Actually, we before we have this one center, it was situated in 5 places all over the town. And the problem is that you cannot develop the healthcare professionals to be good enough to do the services they have to. We cannot be now we are a learning organization doing feedback, supervision, and so on. You cannot do that if you have it in 5 different places, because here we have the critical mass of healthcare professionals, but we also need to have, as I said in the end, the critical mass of patients to do this kind of person-centered and differentiated care. If they are out in 5 centers, there are maybe only 200 or 300 patients every year. Now we have these 1,200 diabetes patients every year, and we actually trying to reach 1,500 or 1,800 in the coming years.
Yeah.
So I think this is you should not have. You should really. I mean, you could not be. I was thinking of it. I think you should have this population of 1,200 or 1,500 patients a year if you should succeed with this.
Critical mass and critical staff to handle those factors here. So talk a little bit more about the fact that you're not just a diabetes, or you have been a diabetes center for some time, but now you're expanding into cardiovascular disease, and I think that makes a lot of sense. But why does that make sense for you?
It makes sense because diabetes and cardiovascular diseases are related, actually. So maybe it's almost the same disease, but so that's why it makes sense. It also makes sense because now I have even more healthcare professionals to take care of the patients. But we do not mix, actually, that's maybe important to say, we do not mix our diabetes management, our patient management courses, because it is different. When they're coming to our center, it is different problems they have. But our healthcare professionals can tackle both problems, but the patients are differentiated in different classes. But again, it makes sense, and maybe also because some of the patients, especially with cardiovascular diseases, also have diabetes. Maybe it's unknown, maybe it's known, but then we can just give a brief examination or a class in these patients. We are actually trying to develop another class for patients that have been to heart cardiovascular rehabilitation in our center, and then they can have a class in diabetes management and having this upon the heart disease rehabilitation. Because if they can handle their diabetes, they also handle their cardiovascular disease, or taking care of their cardiovascular disease. That's what we're saying to the patients.
And often it's also sometimes a question about which door you go through first. If you have diabetes, then whether you classify it in the cardiovascular disease area or diabetes happens a little bit sometimes by chance, because often they're so closely related.
But see, in our center, diabetes patients do have cardiovascular disease. This we handle in the diabetes classes, but the patients with cardiovascular disease often have an acute myocardial infarction or have been operated, and they are mainly coming from the hospital, so they have a lot of other problems we are taking care of in these kind of classes. So
cool.
That's how we are organized in Denmark.
Cool. Here's a question about using electronic means from Michael. He says, behavioral change seems to be a large part of how you work. Have you looked into, or are you working with motivating citizens after the interventions have ended by using electronic means? Text messaging, SMSs, encouragements, apps even, or have you experimented with that? And what is your experience if you had any?
Actually, we have. We have worked with one app, in a Danish app. Both during the interventions, we tried actually to the ones that not need a lot of help. They got this app, and then we were advised them using this app, and then we used it after the intervention ended. Actually, we have stopped it because the patients don't use it. They use it in the beginning, and then they just drop out using these kind of apps. And I think if you're by yourself using these kind of apps, it's funny in the beginning, and maybe at the end you don't use it anymore. But I mean, there is a potential here. Actually, we have used the virtual classes using Teams, which we developed during the COVID-19, and we are doing this still because people at work can then maybe join a class in lunch break or when they are coming home from work. So we are working using virtual education programs and virtual training programs. And maybe in the future, if we find a good app, we will use that.
Yeah.
But it doesn't work now.
No. And I can connect to this, your experience about, or your learning about, it's fun in the beginning, but then it kind of fades out over time. So I know for a fact, and you also know that because you have been giving many presentations both in Denmark but also internationally, and we thank you for that. That we do see your center as a beacon and an inspiration for others. So what would you be, I mean, if there's somebody online listening, what would be your advice for a city or somebody who's going into a position like yours? What would be your advice to do? What would you do more of, or what would you not do that you did back in the day, those 5, 6, 7 years ago?
It's really a big and difficult question, actually. I will have the political will and ambition, I think, is crucial. So if you have this, you have an action. For me, it was really nice when I started to have an action plan, because I really didn't know what really to do. So I have this action plan, and I worked it through steadily. And then now when we decided this new action plan, I have develop this together with the politicians and the director of the municipality. So have a plan on how do you want to work, which kind of principles. Have a plan on actually the critical numbers. That's important. Have a plan on how do you develop competences in your healthcare professionals. They should have these kind of pedagogical competences, but they should also have competences in diabetes. If they don't have competences in diabetes, they're not a good diabetes management trainer. And I think work with data. Work with data is crucial to change the behavior in the healthcare professionals. And in the beginning, they didn't like it. They thought it was control of their work. And I said to them, data is for learning. So we use it for improvement of our interventions. And today, actually, they are asking for data before they're starting thinking of new improvements in daily life. So, I mean, there's a lot of things you can do. And if someone would like to, I will. They are very welcome to contact me in the future to have a talk with me and how we did it. I think we also have something on the CCD website on some of our interventions and initiatives, how we have worked in our center.
Yes, and I'll get back to that towards the end. My perspective is also, I think it's one of the critical factors has been leadership, your leadership, but also the team's leadership here. And then I think what you have been really good at is, all organizations have missions and visions and so on, and once you have made them, you forget them. But what you have done in terms of outlining those 5 core values that you're working on, and also demonstrating in practice how you follow those values, and whether that being a person-centeredness and differentiated approach, be working evidence-based, and so on. I think following those core values, but also demonstrating how this what it looks like in practice is something that certainly also drives change and also drives outcomes. And something to a good example to be inspired by. You came from one of the 5, if I recall, from one of the 5 regional, the 5 centers, the health promotion centers before joining this, right? Building this center, what has surprised you the most? Probably, I mean, that either positively or negatively in the years that you've been working with this?
Actually, I haven't worked with healthcare professionals before I came here. I have been a researcher in 15 years, so this was actually a big change for me to lead these kind of healthcare employees. And it has been difficult for me, but also positively. They are so engaged in doing things for the patients or the citizens. And it has really surprised me that they really would like to be really competent in their work, and they're really doing this every day in the center. I mean, this is maybe because of leadership and political will, ambitions, and money to lead this center. We have quite a lot of money. We have also money, external funding. So we really have the strength to have these ambitions, and that's empower and motivate also the healthcare professionals. So that's a positive way to work with this kind of center, I think.
In other places, we've found, as part of the research we've done in other cities as part of City Change Diabetes, that mistrust, particularly amongst the most vulnerable members of society, mistrust in public institutions is an impediment for seeking help and seeking care and so on. Is that something you have experienced at your center, and if so, how have you dealt with it?
Not particularly in our center. I think there are mistrust in our municipality, but it comes more, if it's about in social welfare, we have this mistrust to the municipality. When it comes to health, I don't think we have the same mistrust. You can say that we have not succeeded enough working in the deprived areas. Maybe it's because of mistrust. Maybe it's because of other contextual factors that we now will work with in the EDIT study, the integrated diabetes study in Tingbjerg with Steno Diabetes Center. And now we are actually having this full-time social nurse out there and building up more trust in this area, and maybe also having more people reach into this kind of interventions. But we haven't seen mistrust. I mean, you could also say it in the figures that we have 35% of the population with another ethnic backgrounds, and we have a lot of people with short education as well.
And I think your whole approach to being person-centered and differentiated is probably a very one of the critical factors that you're overcoming whatever mistrust there might be, that people can see this is actually something that puts them in the center and where you listen to their challenges and not just give them that standard 12-week package and then you go work with that. So we are actually out of time now. So thank you very much, Charlotte, both for your presentation and also responding to my questions and the questions that came in online. We hoped for you online that this was inspiring for you, and that you can use some of these learnings to also inspire your work out in the different cities. This presentation has been recorded and will also be available on YouTube on the Cities Changing Diabetes channel. You go to YouTube and then type Cities Changing Diabetes, and then it magically appears at the top of your screen, together with the 7 other episodes that we have of this, where we've covered actually a lot of ground. We will, as Charlotte mentioned, she is willing to answer questions, and if you have any, please send them to info@citieschangingdiabetes.com. Then we will pass them on and make sure that you will get a response from Charlotte or one of her colleagues. And as Charlotte also mentioned, on the citieschangingdiabetes.com site, under Network and Copenhagen, there's a full description of the center, some of the resources, and also a guide to peer support that was also developed a few years ago that can also be an inspiration here. So there's a lot more to learn and also a lot more to be inspired from online if you care to do so. The next CCD round will take place in June. So a couple of months from now, where we will look into health promoting community workshops that the city of Madrid have been doing, that have been focusing on food, physical activity and well-being. So maybe also something that can inspire you in your daily work. So all there is left for me to say is thank you again, Charlotte, for your presentation and your contribution today. And thank you to everyone who joined online. Have a wonderful day wherever you are. Thank you.